Hello and welcome to the latest seminar from the Glasgow Centre for Population Health, supporting new approaches to improve health and tackle inequality. In this videocast, Professor David Williams from Harvard University delivers this timely keynote seminar to explain why and how race matters so profoundly for health. This presentation is one component of a body of work and concerted public health effort led by the Glasgow Centre for Population Health and Dr. Emma Jackson, co-chair of the Scottish Migrant and Ethnic Health Research Strategy Group, in collaboration with Public Health Scotland, to develop understanding of racism and racialisation as fundamental determinants of health in Scotland. It was recorded via Zoom on the 12th of May 2021.
Welcome to this Glasgow Centre for Population Health seminar. We will today hear from Professor David Williams, Professor of Public Health and Professor of African and African American Studies and Sociology at Harvard. More information about his work shortly. Then our panelists will respond with some questions directed to Professor Williams. Our panelists are Claire Sweeney, Director for Place and Wellbeing, Public Health Scotland, Agatha Kibera, Chief Executive, Baba Yangu Foundation, Caroline Lamb, Chief Executive of the NHS Scotland, and Scottish Government Director General Health and Social Care. Then Pete Seaman, Associate Director of Glasgow Centre for Population Health, will provide a GCPH response. Then I will close the event. But first, two things. I'm going to say a little bit about how this event today came about and the work we have done together in GCPH, laterally with Public Health Scotland and with SMERS, Scottish Migrant Ethnic Health Research Strategy Group, which I co-chair with Professor Kate O'Donnell. Then we're going to have about 4 minutes of what we are calling a context setting intervention, read by Professor Helen Minnis of Glasgow University, which sets context because context matters when talking about racism. We will then go directly from that seminar, from that talk, into Professor Williams, who will share his seminar address to us for about 45 minutes. I am Emma Jackson, an academic who works with communities, people racialised in our systems of research, service provision, policy making and government processes in order to evidence and improve understanding of racialisation and racism, how it functions within our organisations, how it shifts and changes within society. Essentially, I work to counteract experiences of those racialized by being interpreted by exactly the same systems that create and sustain the systemic processes of racialization. This event is part of several years' effort with GCPH to bring this conversation to the fore. In 2019, GCPH approached me because they wished to understand and to start to address their own perspectives on racism, which had influenced their own conceptualizations or at times lack of them within their significant bodies of work that they have driven forward. I was pleased to support them. This led to the Professor Laura Sarant seminar, which focused on the inherent barriers within health research and workforce, which prevents the kind of critical thinking required to intellectually and practically engage with what is racism in health. The follow-on event the next day was called Considering Racism as a Fundamental Cause of Health Inequalities, was accompanied by a report making recommendations to the GCPH board, who agreed to resource a specific programme of work on racialised health inequality. Last summer, with the terrible events unfolding within the early pandemic timelines and the subsequent Black Lives Matter protests, a moment occurred which seemed to generate a much wider global understanding of racism, how it functions, and how it creates racialized inequalities. That it was considered a significant challenge in 2019 to even call the event Considering Racism as a Fundamental Cause reflects the landscape then and now. This is the biggest event that GCPH have ever had. There are literally hundreds and hundreds of us here today. When we approached Professor David Williams, his response was, "How can I help?" Thank you, Professor David Williams. You are here today. You are the author of more than 500 scholarly papers in leading journals in sociology, psychology, medicine, public health, and epidemiology. The everyday discrimination scale you developed is currently one of the most widely used measures to assess perceived discrimination in health studies. Over the last 2 decades, you've focused on understanding the multiple ways in which racism can affect health and so much more. I know people are waiting to hear from you, but before they do, we thought it was important for us all to focus for a few minutes on what is racism, where has it come from, and what is Scotland's role in its creation, and how that deep historical involvement has transmorphed globally, nationally, locally into our thinking, our assumptions, our systems, and has ended up with us here today in a seminar to help us develop our collective understanding on how racism shapes our health. What you are about to hear is an abridged version of the introductory address at the Considering Racism as a Fundamental Cause of Health Inequality, written and given by Adebasola Rambazi, an artist and public health worker. We invited Professor Helen Minnis, who is Professor of Child and Adolescent Psychiatry at the University of Glasgow and a member of University of Glasgow's History of Slavery Committee, to read the address. After this reading, Professor Williams will begin his seminar.
Context matters. And to paraphrase Professor Olivetti Otelli, history matters, memory matters for the country we're in, the cities, the buildings, the architecture and materials that surround us. Ideas of racial difference, racial hierarchy, and racism have a history. Scotland is a country with a historical amnesia about the part it played in the othering and enslavement of racialized Africans, the development of colonies on seized lands, and the imperial civilizing missions of the British Empire in the last 400 years, whilst also surrounded by the built heritage, the legacy of the wealth created in a brutal, dehumanizing industrial complex that fed the plantation system in America and the Caribbean. The concept of race and racialization are inextricably linked to enslavement of captured Africans, forcibly transported across the Atlantic, and children codified at birth for chattel slavery. And Scotland is inextricably and disproportionately linked to that industry. The slave economies and the built environment that devised and cultivated racialization and its inherent hierarchy. The roles that the Scottish performed in these economies and the industries were dependent on enslaved labour can be seen in the institutions that still surround us today. The banking legacies, Scottish universities with their large-scale intellectual migration to all parts of the empire has accounted for 1/3 of Western Europeans who went to the American colonies. The city chambers in Glasgow, carvings which gloriously display the people of the empire bringing forth gifts, a symbol of Glasgow's claim as the second city of empire. Investors in the trade included Scottish landowners, trustees, tradesmen, physicians, military officers, university professors, meaning profits were distributed beyond merchant classes to supporting industries, tanneries, breweries, bottle works, and ironmongers. It is an obfuscation of reality to mention tobacco lords, and not to think critically about how plantations operated. The institution and industry of chattel slavery existed for much longer than it has been abolished. Our understanding of what is racism has to grow in order to address it in our systems and processes. Anti-racist practices in Scotland largely focus on tackling interpersonal racism, from microaggressions to verbal and physical violence. It is not simply the calling out of that which is needed. It is the implementation of action to prevent it occurring. It is the structural racism embedded within our collective thinking and processes that leads to disadvantages in accessing economic, physical, and social resources, and institutional racism that is the core issue. A Scotland that chooses to remember its full history, which includes involvement in this brutal inhumanity, is part of repair and reparation. It's disingenuous to assume reparation is just about handing cash over, although don't get it twisted, that has to happen. But reparations would also involve addressing the continuing impact of colonialisation and racialisation. It is in addressing how our systems and institutions maintain and reinforce inequality. It is in addressing the collective amnesia by ensuring that more are educated in the historical facts to build collective memory. It is decolonisation of systems, more specifically of minds, the way we see and think in our research, our data, our policies, and our services. Let us sit with it, begin to critically think how that context, how this history, how the forms of racism it created shape our health.
And I want to add my good afternoon greetings to everyone and say it's truly an honor and privilege to join you today and to give you an overview of research on racism and health. I have a lot of territory to cover, so I'm going to just jump right into my presentation so that we have a good time for the panel discussion afterwards. What I want to do is to talk about racism and give you examples of the kind of scientific evidence we have of the role that racism plays in terms of health. So I want to begin with COVID-19, this pandemic where everyone is. Here is data for the United States, deaths through early March by race and ethnicity in the United States. And these are age-adjusted odds ratios. So comparison group is the death rate for the white population. And you can see the indigenous or Native American or American Indian population has a death rate 2.2 times higher. The Latino or Hispanic, I'll use those terms interchangeably, is 2.4 times higher. The Black population is twice as high. And a very small population in the United States, Native Hawaiians and other Pacific Islanders, is 2.6 times higher. The Asian population has a death rate identical to that of the white population, although there's great heterogeneity within the Asian category and there's variation across specific Asian groups. But here is the bottom line is, you can see that what I would call the populations of color, the historically disadvantaged populations, all have an elevated mortality rate from COVID-19 compared to the white population. Sometimes when I talk about that, I don't think this audience needs this, but people confuse the higher death rate for populations of color to mean that the majority of people or most of the people dying are persons from disadvantaged racial ethnic backgrounds. And so what I've shown here is the actual number of deaths. And you could see there were, through the early March, 300,000 white persons who had died compared to 89,000 Hispanics and 73,000 African Americans or Blacks. If I look at data and where I have data available, I'll show you data for really, it's largely data from England and Wales. And here are the age-adjusted death rate odds ratios compared to the white population for the Black, the Bangladeshi, Pakistani, and the Indian population in the UK. This is the data for men. And you see even larger gaps than we saw in the US, 4.2 times higher for Blacks, 3.6 times higher for Bangladeshi, Pakistani males. And then here are the data for females as well. You see a similar pattern. So quite strikingly large inequities in health across two societies. I'm showing you linked to racial, ethnic status. Just to talk about the impact that the pandemic and these racial disparities have had on overall health in the United States. This is a national report that came out late last year showing the life expectancy for the United States for the first 6 months of 2020 compared to the prior year, 2019. And what the data showed was that life expectancy as a result of the COVID-19 pandemic had declined by over 1 year on average in the United States. But that decline varied by racial ethnic categories. It was a decline of 3 years for Black males, 2.4 years for Hispanic males, 2.3 years for Black females, 1.1 years for Hispanic females, 0.8 of a year for white males, and 0.7 of a year for white females. So we have not seen declines in life expectancy of 3 or 2 years for any group in 100 years in the United States. So these are quite striking data of the impact of the pandemic in general and the disproportionate impact of the pandemic on racial ethnic minority populations. So the question is why? What drives these large racial inequities in health? And the first thought that would come to my mind was what I would call socioeconomic status or social class. It is a powerful driver of inequities in the United States, but also around the world. And then if socioeconomic status, income, education, occupational status, wealth is a powerful driver, there are large racial ethnic differences in socioeconomic status. And I want to illustrate that with data for the United States to begin with. Here is median household income by racial ethnic status in the United States for the year 2018. And I like to translate that in a way that you can't miss the point. So I'm now showing you the same data in the prior slide. I'm just standardizing on the median household income of white households as $1. And you can see for every dollar of household income white households receive, Asian households receive $1.23. Two things to keep in mind about the Asian data. 70%, almost 70%, 68% of all Asians in the United States are immigrants. And they have come to the United States with very high levels of education. And it's not surprising they have relatively high levels of income. But secondly, and more importantly, on average, Asian households have more persons contributing to household income on average than any other group. So that if I had shown a per capita or per person measure of income, whites would have the highest level of income. But let's look at the historically disadvantaged groups, Hispanics or Latinos. For every dollar of household income white households received in 2018, Hispanic households received 73 cents, and American Indian and Black households received 59 cents. This is national data for the United States in 2018. What is stunning about the 59 cents figure for Blacks is that it's identical to the Black-white gap in income in 1978. You heard me correct. I did not misspeak. 1978 was the peak year of the narrowing of the Black-white gap as a result of the civil rights policies of the 1960s and 70s and the anti-poverty policies of the 60s and 70s, and the gap had been narrowed to 59 cents. And the gap in 2018 is still 59 cents. Most of my students and most Americans think that we have made a lot more progress than that. Now, has the gap been stable at 59 cents figure since 1978? No, it fell through the decade of the 1980s, the decade of Reaganomics. We call it. Ronald Reagan was the president who believed that a rising tide would raise all ships. In fact, the gap fell to as low as 54 cents during the 1980s, and it wasn't until 1994, early into the presidency, that it got back up to 59 cents, and it's a penny up and down since then. The bottom line is, though, racial ethnic status dramatically predicts relative levels of income in a society. Here is data for England and Wales showing for every pound, I just translated it quickly, for every pound of weekly income the white majority earns. Other whites, mainly Eastern European immigrants, earn 79p, Indians earn 86p, Pakistanis 57p, Bangladeshis 52p, Chinese 76p, Blacks from the Caribbean 77p, Blacks from Africa 60 pence. These large racial gaps in income markedly understate racial gaps in economic status. What do I mean when I say that? Well, income captures the flow, salary and wages as the flow of resources into the household. It doesn't tell us much about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. Wealth captures home equity. It captures your check-ins and savings and investments and other property that an individual owns. And if we look at the latest national data on wealth by race in the United States, for every dollar of wealth that white households have, Black households have 10 cents and Hispanic households have 12 cents. So there are huge racial ethnic gaps in wealth in the United States. There are also huge racial ethnic gaps in wealth in England and Wales as well. For every pound of wealth that whites have, Indians have 95 pence, Pakistanis 50 pence, Blacks from the Caribbean 20 pence, Blacks from Africa and Bangladeshi 10 pence. So across two societies, you see these racial ethnic categories really capturing differential access to economic resources. And what low economic status means is we are all in the same boat, the same storm of the pandemic, but we are in different boats. When you lack economic resources, you are more vulnerable. Your boats are less able to weather the storms because you have no cushion when you have no wealth. You can be one paycheck away from being homeless or being able to feed your family. When my career started, most researchers thought that the racial ethnic differences in health were simply a function of racial ethnic differences in income and education. And if you looked at persons of different racial ethnic groups, let's say Blacks and whites in the United States, at the same levels of income and education, race wouldn't matter. We now know that life is more complicated. I'm drawing here in a paper I published with colleagues back in 2010. It's national data for the United States, and we are looking at life expectancy at age 25. At age 25, the average white person lives 5 years longer than the average Black person. So there's a 5-year racial gap. But if we look within education, the patterns are similar for income, but I'll show you the education data in the interest of time. There is a 6.4-year gap between whites who have a college degree and whites who have not completed high school. So that 6.4-year gap within the white population is bigger than the racial gap of 5 years. And within the Black population, there's a 5.3-year gap between the most highly educated and the lowest, the group with the lowest level of education. At the same time, at every level of education, race still matters. So white high school dropouts live 3.1 years longer than Black high school dropouts, and the gap widens, surprisingly, as education increases, with a 4.2-year gap between Black and white college graduates. And this is national data for the United States. And here we see a stunning finding. The best off Blacks, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college, lower life expectancy than whites who have finished high school. So what do these data tell us? They tell us that there's something about your income and education that drives health regardless of your race. But there is something else about race that matters profoundly, even after we've taken income and education into account. And just to give you a quick example of the same phenomenon, I'm not going to spend a lot of time on these data. Here's the data I showed you before of England and Wales. The age-adjusted death rate from COVID-19 for Black males is 4.2 years after adjusting for urbanicity, income, education, household tenure, health, a broad range of factors. It's still reduced to 1.9. It's still almost twice as high, 1.8 for Bangladeshis. And you see a similar pattern for females. Here is the age-adjusted rate compared to that adjusted for a broad range of socioeconomic status indicators. So across two societies, I'm showing you race still matters even after you've taken socioeconomic inequities into account. So why does race still matter? And so researchers have been asking the question, could racism be a critical missing piece of the puzzle to help us to understand the persistence of these racial inequities in health? And when I say racism, I am not primarily referring to the beliefs and behavior of individuals. I'm talking about a social system, a system that interacts with other social systems. The arrow goes both ways. It shapes them and it is being reshaped by them. The legal, political, economic, religious, historical factors all drive this system that I am calling racism. And this system categorizes and ranks population groups. It devalues and disempowers some groups and differentially allocates opportunities and resources to groups. Fundamental to racism is this ideology of inferiority, that there's a ranking of human populations and some are superior and some are inferior. At the individual level, it can lead to negative attitudes and beliefs, prejudice and stereotypes, and it can lead to differential treatment, discrimination by individuals and societal institutions. But the core point is that I think of racism as a system. I want to talk about mechanisms of racism, using institutional racism in the way that social scientists used it back in the 60s and 70s. Today, more commonly, the term structural or systemic racism is used. But I am using them relatively interchangeably in this context. And I think it's important to distinguish the individual from the structural or institutional mechanisms. And one structural, upstream, systemic, institutional mechanism I have studied is residential segregation. It's a legacy of racism in the United States, where your race determined where you were allowed to live, what neighborhoods you were allowed to live in. That has no longer been legal since the mid-1960s, but a structure that has been locked in place by the 1940s is still very much in place in America today. John Sell was actually a British from, but a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa early in the 20th century looked across the Atlantic and saw segregation and how well it was working in the United States and said, brilliant, we can implement that in our country. So they got the idea of apartheid, he argues, from segregation in the United States. Importantly, he says that residential segregation by race was one of the single most successful domestic policies of the 20th century in the United States. And why would he say that? What does segregation really do? Well, imagine with me that segregation is like a toxic emission produced by an industrial plant. It's like carbon monoxide. It's often imperceptible, but as soon as it shows up in a community, valuable resources disappear, like good schools, like safe playgrounds, like good jobs, like a healthy environment, air and water, like safe housing and access to high quality transportation, and even access to high quality medical care. All of these factors linked here are factors that have been shown in research in the United States to be linked to place, to link to where you live. In the US, researchers now say that, we say the zip code, but your postal code is a stronger predictor of how long and how well you live than your genetic code. Let me show you some empirical data. These are two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, both colleagues at Harvard University. They did a study of the 171 largest cities in the US. And they said because of segregation, there's not even one city where whites live in equal conditions to those of blacks. And that the worst urban context in which whites reside is considerably better than the average context of black communities. And someone paying attention will notice that's from a 1995 study. So you say, Professor Williams, how have things changed? So I'm going to draw here on the work of a great colleague of mine, Professor Dolores Acevedo Garcia. She has created a neighborhood opportunity index where she's ranking every census tract. It's a large geographic area of 3,000 to 5,000 people on 29 different indicators of quality or opportunity story of opportunity for children. Things like the quality of elementary schools and the graduation rates from school and the income levels and home ownership rates and the quality of the air, water, and soil and resources for health like access to green space and healthy food outlets. These are just examples of the 29 different indicators that she put together in this database. And what she shows, if you look at the 100 largest metropolitan areas in the United States, 67%, 2 out of every 3 Black children are residing in a very low or low opportunity neighborhood. That is also true for 58% of Hispanic kids and 53% of Native American children, compared to only 1 in 5 white or Asian children are living in a very low or low opportunity neighborhood. If you look at the opposite end, you see that almost 2/3 of all white and Asian children live in high or very high opportunity neighborhoods, compared to 1 in 5 Black or Hispanic kids. So opportunity at the neighborhood level is striking in the United States, and it is a driver of even the racial differences in income and education that I spoke about earlier. Here is a study published by another Harvard colleague, Professor David Cutler, an economist, using fancy econometric models, looking at national data for the United States. He shows statistically, if you could eliminate residential segregation in America, you would completely erase Black-white differences in income, in education, and in unemployment, and reduce Black-white differences in single motherhood by 2/3. All of these striking racial differences that are often interpreted as due to culture, due to differences in values, are driven by opportunities at the neighborhood level. One more empirical study. This one from another Harvard economist, Raj Chetty. He has done an amazing intergenerational analysis. He's looked at census data for the United States. That's all data for all places in the United States from 1989 to 2015. And he asked a simple question. Let's begin by looking at Black and white households that start out life, the children start out life with their parents at the same level of household income. How are the children doing in the next generation? And he finds that in 99% of census tracts in America, Black boys who start out at the same level or controlling for parental income have lower levels of income than their white counterparts. Why? Because they live in neighborhoods that differ in access to opportunity. Black boys do just as well as white boys if they live in a neighborhood with good resources. The challenge is such neighborhoods are few and far between in the United States. So again, evidence that it's opportunity at the neighborhood level that drives these differences. I want to show you some data thinking of England. This is a report looking at segregation, and they point out that segregation levels in Europe, Western Europe, are rising, while in North America, they are declining. The patterns, though, are somewhat different. Race is an important, but it's a secondary factor. The first major factor is religion. Is being Muslim is a large predictor of segregation in Western Europe. And here is data for Britain from this report showing the level of segregation is highest for Bangladeshis and Pakistanis. An index of dissimilarity score of 61 means that 61% of Bangladeshis would have to move to have an even distribution of Bangladeshis and whites in England, for example. So it's evidence that although the histories of the countries are different, but there are some processes that are similar, not identical, but similar in terms of producing inequities. Another way to look at that data in England is the percentage of ethnic group living in the most deprived 10% of neighborhoods in England. Now, this is the most deprived 10% of neighborhoods. If all groups were evenly represented, you would see all of the groups at 10%. But you can see the overrepresentation, 31% of Pakistanis are living in the most deprived 10%, and 28% of Bangladeshis, and 20% of Black Africans, and 19% of Arabs, and 18% of Blacks from the Caribbean. So again, I'm showing you not identical, but similar processes occurring across two societies in terms of access to opportunity and the levels of deprivation at the neighborhood level being powerful predictors. What am I really saying? I'm saying that the large racial inequities we see across these two societies in income and education and wealth do not reflect a broken system. Instead, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. These inequities then are not accidents or acts of God. They show the ways in which these upstream structural mechanisms of racism has produced a truly rigged system. And research in the United States indicates that when you are low in economic status, and then on top of that, you live in disadvantaged, segregated neighborhoods, it leads to higher levels of exposure to all kinds of stressful life experiences and also greater clustering of these stressors, whether it's economic stressors, psychosocial stressors, and physical and chemical stressors. For example, a study in the United States indicated that if individuals who live, generally poor people and persons from populations of color, live in neighborhoods with high levels of air pollution, when exposed to COVID-19, they were more likely to get it. It was more likely to be severe, and they were more likely to die of it. So the physical, chemical stressors actually were making an added contribution. For the researchers in the audience, I want to make the point that these distinctive social contexts of living in areas of deprivation with lack of access to opportunity means that their normal, adaptive, and regulatory systems can be affected by the accumulation of adversity. In other words, you may see some biological variations across racial ethnic groups that do not reflect innate biological differences, but reflect adaptation. Biology is not static, it adapts to environmental conditions. So it kind of reflect biological adaptation to the residential and occupational conditions of Blacks. So that if you see biological differences, don't assume that they necessarily reflect innate differences. I've talked about racism as a system. I've talked about one structural or institutional mechanism of racism, and I want to now talk about another path through which racism affects health, and that is through discrimination, individual level discrimination. Martin Luther King said in '67 that discrimination was a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. Now, that's a hypothesis that could, in fact, be tested. We now have a lot of research that documents, yes, experiences of discrimination matter profoundly for health. There are many ways to capture discrimination. In the interest of time, I'll just talk about a scale that was mentioned in the introduction, the everyday discrimination scale. It's a scale I captured. It's one of multiple measures I developed, but it's the one that has been the most predictive of health outcomes. And what's striking about that, it just captures little indignities. Being treated with less courtesy and less respect and receiving poorer service than others. And people acting as if they think you are not smart, or if they're afraid of you, or they think you are dishonest, or they are better than you are. And what research indicates is that everyday discrimination is a powerful predictor of variations in health. I have a student, a doctoral student, doing a meta-analysis now, have identified more than 450 published papers linking the everyday discrimination scale to other health outcomes in multiple countries of the world. And this slide just shows you, it predicts incidence, new cases of metabolic syndrome, of cardiovascular disease, of breast cancer, of type 2 diabetes, of a number of risk factors, behavioral factors, a number of subclinical indicators of heart disease like coronary artery calcification or intima media thickness or heart rate variation or visceral fat or AFib. It predicts high blood pressure. It predicts poorer sleep quality and quality. It predicts higher levels of inflammation and cortisol and telomere length and indicators of biological dysregulation as captured by allostatic load. It predicts obesity. It predicts lower levels of utilization of the healthcare system. It predicts higher levels of mental disorders. Just a sprinkling of some of the outcomes that have been associated in studies of discrimination. And we now have studies from the United States, from South Africa, from Australia, from New Zealand, showing that when you look at a racial gap in health and you adjust for income and education, and there still is statistically a residual effect of race, that effect is further reduced when you add a measure of self-reported discrimination. So we now have empirical evidence that indicates that discrimination is an added contributor to racial ethnic differences in health. Chester Pierce was a Black psychiatrist at Harvard back in the 1970s and 80s. He published a paper in 1970 where he coined this term microaggression. And he talked about these, what I call everyday discrimination. He called them the daily assaults to Black dignity and Black hope. He argued that they are incessant and cumulative. He predicted what these studies have found. He said any single one may not be gross, but it is a major way because of this never-ending gratuitous offenses that he called microaggression. And the science at the time did not exist about this. This was his speculation, but the science now documents this powerfully. The science is also indicating that there are hidden ways in which stressors linked to discrimination and racism adversely impact health. Here is a study I did with a postdoctoral fellow with me some time ago, where we looked at not the discrimination that people experience in their day-to-day lives and normal lives, but what happens in online contexts. And this was of young youth ages 14 to 18 that found that statistically adjusting for a global measure of adolescent stress, adjusting for a measure of offline discrimination, we found that experiences of discrimination in online contexts was positively associated with high levels of depression and anxiety symptoms. So a unique contribution to experiences of discrimination online. Professor Tynes has recently published a paper back in 2019 looking at Black and Latinx adolescents 11 to 19 years old and find that what she calls exposure to online traumas, that is, traumatic images or videos of someone from their racial group being beaten by the police, arrested or detained, or being shot by the police, predicted higher levels of post-traumatic stress disorder symptoms and depressive symptoms in these 11 to 19-year-old young people. This is a study published in Lancet I did with one of my former students. We used one data set and looked at every police shooting in the United States of Black and white individuals over 3 years. And then we linked it to another data set that had the mental health of the population in every state in the United States. And we used a quasi-experimental design, and we were able to link a police shooting to the mental health in the state in which it occurred. And what we were able to document, that every police shooting of an unarmed Black person, mainly males, but unarmed Black person, led to worse mental health, declines in mental health, not for the family and the friends, but for the entire Black population in the state in which that incident occurred for the next 3 months. There was no effect of a police shooting of an armed or unarmed Black on the mental health of whites. What was also important here is this was a very specific effect. It was only police shootings of unarmed Blacks that led to worse mental health. If police had shot a Black person who was armed, there was no negative effect on mental health. It's only the shooting of an unarmed Black person, which suggested to us that it's the perception that this incident was unfair and unjustified that led to the worsening mental health. Because if the police shot an unarmed Black person, it could be you, it could be a family member, the person wasn't doing anything wrong, they were unarmed, it increases the sense of personal vulnerability to this happening to individuals. One last point that we often don't think about when we think of these stressors and their impacts on populations of color. I've talked about the fact that there are these racial differences in mortality in COVID-19. Well, what we see for COVID-19, we see for most of the leading causes of death. there are racial differences in health. It means that Blacks and Hispanics are dying at elevated rates, especially at younger ages. What does that really mean? This paper by Professor Deborah Umberson from University of Texas shows that nationally, compared to whites, Black children, because of these higher rates of death, are 3 times as likely to lose a mother by age 10. Black adults are twice as likely to lose a child by age 30 and a spouse by age 60. So this earlier onset of death and the more frequent occurrence of death is a unique stressor that also adversely impacts these populations over their lifetime. And what are the consequences? What does it mean to be living in a society with this constant barrage of stressful life experiences linked to low economic status and linked to racism? In the United States, scholars are using terms like accelerated aging or premature aging or biological weathering to capture a phenomenon that is now well documented, that Black people in America, for example, are literally aging biologically more rapidly than whites. You see, one term used by Arlene Geronimus is biological weathering. And what the point she's making is that your age not only captures how long you have lived, but when you live in a bad environment, your age is capturing the physiological wear and tear. It's capturing the degree to which you are being biologically compromised as a result of the cumulative impact of repeated stressful life experiences, and you're literally aging biologically more rapidly. Think of it this way. Imagine a drop of water falling from the rooftop of the building you are sitting in to the concrete sidewalk below. If water dripped today, it's no big deal. But if water dripped day in, day out, week in, week out, month in, month out, the sidewalk below would become weathered. It would become eroded by the constant exposure to adversity. And the evidence is, yes, that is exactly what is happening to populations in the United States of weathering. One way we can see that is the earlier onset of disease. In the interest of time, I'm showing you one outcome, just high blood pressure. And you could see at age 50 to 64, 41% of whites in the United States, this is national data for the United States, have hypertension compared to 61% of Blacks. That pattern is true for diabetes, for heart disease, for stroke, for kidney disease. I'm showing you one outcome in the interest of time. And how does this all matter for COVID-19? Here is data from a study of 12 hospitals in New York City, almost 6,000 patients. And this is the level of comorbidities in these patients. 57% had hypertension, 42% were obese, 34% had diabetes, and so forth. Importantly, only 6% of the patients hospitalized for COVID-19 had none of those comorbidities, and only 6% had one. So 88% of them had 2 or more. And those who were hospitalized, those with more severe disease, were more likely to die. And what I'm showing you is that all of these stressful life experiences are exactly what the research suggests, that puts these individuals at earlier onset of disease and higher risk of chronic disease as a result of these stressful life exposures. So I've talked about racism, segregation as a structural institutional mechanism of individual discrimination. Let me touch base briefly on cultural racism that is deeply embedded in the culture. And there are negative racial stereotypes that in turn trigger racial discrimination. Where do the stereotypes come from? A group of researchers have put together a study, a database that is American culture. It has about 10 million words. The books, newspaper articles that an average college-educated American would read over their lifetime. What's brilliant about this is if you've got American culture in a database, you can say to that database, when the word Black appears in American culture, what adjective co-occurs with it? Well, the most common adjective co-occurring with Black is poor, then violent, then religious, then lazy, then cheerful, then dangerous. When white occurs, wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, when female occurs, distant, warm, gentle, passive. When male occurs, dominant, leader, logical, strong. Here are stereotypes in this database of American culture. The number next to it is a measure of associative strength. It's not a simple correlation, but think of it that way. If the two things were always tied together, it would be one. So the larger the number, the more closely tied they are together. And you see there are some negative stereotypes for whites, but you see the predominance of negative stereotypes for blacks, and the associative strength is much higher. What this says to me is that when a police sees a black male and reacts, and assumes that person to be more violent and dangerous and lazy than that person actually is, we're not necessarily dealing with a bad police officer. We're dealing with a normal American who's acting in what is deeply embedded in his subconscious because he was raised in this society. These stereotypes lead to implicit biases that are normal and natural. All humans have them, and they shape our interaction with individuals. In the United States, we have high quality scientific evidence that documents implicit bias in medical care leads to racial ethnic differences in the quality and intensity of care. This is a very famous report published in 2003 by the National Academy of Medicine, the highest scientific body in the United States, reviewed the science. I served on the committee back then that documented across virtually every therapeutic intervention, blacks receive poorer quality care than whites. Here's an example of one study that was in that report. There were 180 studies, and 80% of them found racial differences in the quality of care. This was a study that looked at patients with a broken bone in the arm or legs in an emergency department. Does the patient get pain medication? 55% of patients who were Hispanic did not get pain medication, compared to 26% of patients who were whites. Even after statistically adjusting for other things, the single biggest predictor was the patient's race, ethnicity, determined whether or not the patient got pain medication. Here is a study by Lisa Cooper from links implicit bias as measured in the provider with the quality of the patient-provider relationship. And when there are higher levels of implicit bias, there is a poorer doctor-patient-provider relationship based both on the objective assessment of a videotape of that encounter as well as reports of the patient about the last encounter. Here's a randomized controlled trial done in Northern California that took black men and gave them a coupon to get a free health screening at a Saturday clinic at a nearby hospital. The black men were randomized to see a black doctor or see a doctor who was not black. And what the study found was that black men who saw a black doctor were 29% more likely to talk about other health problems, 47% more likely to be screened for diabetes, 56% more likely to take the flu vaccine, 72% more likely to do screening for cholesterol. So there was much greater engagement with healthcare when they were seen by someone of their own race. Here is a study published in 2020, a disturbing study of 1.8 million hospital births in the state of Florida between 1992 and 2015. When cared for by white doctors, black babies born in the state of Florida are 3 times more likely to die than white newborns in the hospital. This disparity is cut in half when black babies are cared for by a black doctor. We don't know what all the processes and mechanisms are, but it is a disturbing finding. And it does make the point that diversifying the workforce to meet the needs of all patients is an important priority. In the United States, we have a long way to go. In 2014, there were 27 fewer black males in the first year of medical school in America than in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2019, only 5% of practicing physicians are black, 6% are Hispanics, 0.3% are indigenous. There is good news. The good news is that even if you are not of the same race, But if you are characterized by scoring high on a scale of cultural competence, this study found there are no racial inequities in the care of the patients served by those providers. This cultural competence scale had 20 items. I'm going to show you just a few items in the interest of time. Physicians scoring high in cultural competence agreed that family and friends are as important to health as doctors, that social history contributes to how they care for their patients, that they were familiar with the lay beliefs their patients have, that they ask their patients about alternative therapies they use, they find out what their patients think is the cause of their illness, they involve their patients in decisions about their health care. What emerges just from these factors is a provider who respects their patients, listens to them, takes them seriously, and that seems to make a difference in the quality of care. So I've talked about the mechanisms of racism, and all of these mechanisms leads to inequities, and these inequities reinforces the stereotypes, which goes back and reinforces the system of racism again. What else can we do in addition to improving the diversity of care? We need to create what I call communities of opportunity to minimize and neutralize and dismantle the systems of racism that create inequities in health. So most of the action needs to take place outside of the healthcare system. We need to enrich the quality of neighborhood environments and improve housing quality and the safety of neighborhood environments. These are some of the strategies: invest in early childhood, reduce childhood poverty, enhance income and employment opportunities, improve neighborhood and housing conditions, enhance opportunities for marriage, raise awareness levels of inequities. I will talk briefly as I wrap up here quickly on just some of these. I don't have time to talk all of these in specific. But the point is, in the US and elsewhere, we have data that shows multiple strategies that increase income levels at a household level. No health intervention leads to improved health. So added income at a household level leads to improved health with no health intervention. Let me give one example of family structure in the United States that gets a lot of attention. Determinants of family structure. Imagine the decision of, and these were studies were done with heterosexual couples, but imagine the decision of two people to get married as the most personal individual decision individuals can make. But nationally in the US, marriage rates are positively related to average male earnings, and marriage rates are inversely related to male unemployment. So when male unemployment increases nationally, marriage rates decline. Robert Sampson, I mentioned him before, he has shown that residential segregation leads to lack of access to jobs and high male unemployment and underemployment. These in turn leads to high rates of out-of-wedlock births, female-headed households, the concentration of poverty, and higher rates of female-headed households lead to lower supervision of adolescent males. And it's these factors predict higher levels of adolescent risk behavior, including crime and violence. So it's racial differences at the neighborhood level in the availability of jobs, concentrated poverty, opportunities for marriage and family structure that predicts both family structure, but also the high risk behavior among adolescents. What would happen if we provided young men with increased economic opportunity? There is a study, a research in the US that has looked at that. Active duty military service, when men don't have to join the military, but the military provides stable employment. This leads to marriage over cohabitation, increased likelihood of first marriage, greater stability of marriage, and all of these effects greater for blacks than for whites. So what does it tell us? Increasing economic opportunity for males leads to what many conservatives want to see, increases in marriage. It's not cultural values, it is about economic opportunity. Let me wrap up by talking about a dramatic transformation of a neighborhood environment in the US and also talking about a barrier we need to address. This was a very disadvantaged neighborhood with high rates of crime, poor quality housing, very low employment among adults who resided there, and terrible education. There's been a dramatic transformation, violent crime down by 70%, high quality mixed income housing, all adults gainfully employed, one of the best schools in the state of Georgia where this was done, showing that it's possible using the purpose-built community model that is comprehensive, integrated, place-based solutions, cradle to college, pathway for education. We can do it. Where there's a will, there's a way if we make up our minds to do it. What else do we need to do? We need to think of resources at the end. High levels of social support reduces some of the negative effects of the stress of discrimination on health. High levels of religious involvement in the US among Blacks reduces the negative effects of the stress of discrimination on health. And here is a study from Canada looking at Indigenous community and finding that high levels of protest, advocacy, and empowerment on the part of the local community leads to lower levels of suicide among the young people who live there. What are the barriers we need to overcome? What is holding us back? I want to say there are 3 communication challenges. Most Americans don't know that racial inequities in health exist, even though the data have been reported for 100 years. We then need to develop political will, and we need to build empathy. W.E.B. Du Bois in 1899 said the greatest problem with Black-white differences in health, 1899, was the fact that we lacked empathy. He called it the peculiar indifference. Today, researchers document a racial gap in empathy across contexts. This racial gap in empathy is not seen in American white children at age 5. It becomes evident at age 7, and it's pronounced by age 10. So we see a racial gap very, very early in life. What do we need? We need a renewed commitment to equity. Equality is giving everyone the same thing. Equity is giving everyone what they need in order to thrive. As Plato put it, there's nothing so unfair as the equal treatment of unequal people. Or as Martin Luther King has put it, true compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. Racism is an edifice that has produced beggars, and it needs to be restructured in our societies. Thank you so much for your time and attention.
Professor Williams, thank you so much for that address. I'm still processing. There's so much information there that you have shared with us. I would like to invite that Claire Sweeney, Caroline Lamb, and Agatha Cabrera put on their screens. And we have to have some questions from the panel towards you if they've had some time to process some of what you've said. I mean, obviously, you know, I understand your work and have followed it. Some people are perhaps newer to it. But I'm going to go to you first, Claire, to ask Professor Williams a question from your direction.
Excellent, thank you. And thank you so much, Professor Williams. I think probably the only right response is to say that it's really, really hard to know how to respond to that. Really, really powerful. I'm struck by a lot of the language that you used, being very particular, and lots for us to go away and think about. I think one of the urges is to say, well, how do we respond and what do we do next? And in truth, I think this isn't about necessarily running to do things. It's about taking a really different approach to what might have gone before. And I think it's right that we feel uncomfortable. We need to listen and learn. We are really proud at Public Health Scotland to be involved with GCPH on the programme of work, and we know and recognise that the pandemic has had a particularly disproportionate effect in Scotland as it has in the rest of the globe, and we would definitely recognise a lot of the kind of key points that you raised from the rest of the world as having applicability in Scotland for sure. So we've got evidence, but we don't have all of the answers. But I think on reflection, the last year, unfortunately, means we're at quite a unique point in recent times. We in Scotland have the advantage of human rights legislation coming on track shortly, which again is potentially a significant step forward. what I think really struck me from the presentation was you talked about place, education, police, health, income, economics. And I think for me, it's not just about the health and care response to it. I think it needs to be far, far more ambitious than that if we're going to do this well. So my question's twofold, Professor Williams. How does Scotland learn from the best? Who are they? Where are they? Who do we look to? And secondly, for Public Health Scotland as a brand new organisation in Scotland, we intend to review all of our contributions and practices and processes to see where action might be needed to address racism and promote race equality. So how do we make best use of your work to make sure that we do as good a job as possible and make the most positive impact? So how do we learn from the best? And a bit selfishly, how does Public Health Scotland make sure they apply your work and thinking to make sure we make most tangible positive changes across Scotland? Thank you.
Thank you so much for your thoughtful question. Clearly, the challenges, let me put it this way. I am not aware of any society in the world that has solved this problem. I have data, and I didn't show them in the interest of time, of racial ethnic differences in health for the African descended population in virtually every country in Latin America, for the indigenous population in virtually every country in Latin America. So it's a global problem. Where societies differ is, the US is very good at collecting data on race ethnicity. You know, there's some countries like France, it's illegal to collect data on race ethnicity in France. So we don't know in certain countries, but everywhere we have data, we see a similar pattern, even though some of the particularities of the history is different. So there is no single society. I wish I could tell you there was one I could point you to and they have done it right. I'm unaware of that society if it exists. So the challenges, we do have examples, and you will get a copy of the slides. There is a paper that is cited when I talk about how we need to create communities of opportunity that I wrote with Lisa Cooper. It's open access, so anyone can Google it and get the PDF free at no charge. But it reviews the science, and I just highlighted some of them in bullets on the slides. It's really about dismantling the structures of racism. It's really about creating, it's about addressing the social determinants of health. It's about creating opportunities at the level of neighborhood in terms of access to opportunities that in fact facilitate good health. In the United States, for example, and we may be doing worse than other countries on this regard, but the general point is true elsewhere as well. And that is, if you look at our medical care expenditures, only about 3% of our expenditures are on prevention. So so we don't have a healthcare system. We have an illness care system. We have a system that that functions like a repair shop, does a good job taking care of you once you get sick. But it's not a drive of whether or not you get sick in the first place. And that has to do with what are the opportunities to be healthy in the places where people spend most of their time, our homes, our neighborhoods, our workplaces, and how do we build health into those contexts and build the opportunities for health. So those are the key things. It's early childhood investments. The data there are striking. Again, we haven't solved the problem in the US, but there are a number of randomized controlled trials where one study called the Abecedarian Project in North Carolina, at birth, babies were randomized, poor babies, 80% of them Black, randomized to be in an early childhood development center, birth through 5. By age 20, higher levels of academic performance, of vocational skills, less likely to smoke, lower depressive symptoms. By the mid-30s, lower levels of risk factors for heart disease, all the markers of metabolic syndrome, striking difference in obesity, striking difference in blood pressure, and other risk factors for heart disease, simply by what we did for them early in life, putting them in a very highly supportive environment with intellectual stimulation, good nutrition, good access to medical care, and so on. So the evidence is quite good, and the additional income evidence and improving how neighborhood communities, and that's why I focus on purpose-built at the end, because a lot of policymakers I talk to, their knee-jerk reaction, this is so complicated, there's nothing we can do about it, it's too difficult. And no, it is difficult, but we can do it. And there are examples of where we have just transformed neighborhood, including examples from Europe, where we see with no health intervention improvements in health. So I think it's the areas within which we need to work is what's really critically important.
Thank you, Professor Williams. And I'm struck by some examples in Scotland that we could mention too, actually, so that we know there is a path. Yeah, thank you.
Thank you very much. Agatha, would you like to, you're kind of coming from a different perspective, would you like to ask your questions?
Hello, everyone. Thank you for inviting me to participate in this prestigious forum. My name is Agatha Cabrera, and I was invited here today to speak from a perspective of a small organization which is working to support young people, many whose mental health has been affected because of racism. Baba Yangu Foundation is a registered charity that works mainly in Scotland, with some programs also in early stages of becoming established within London. In Scotland, more specifically Glasgow, our charity focuses on mental health issues in the African and Afro-Caribbean communities. Many of the young people who Baba Yangu works with are second-generation immigrants whose parents came to the UK seeking asylum. Our main objective is to eradicate the stigma and isolation associated with mental illnesses in our own communities, while assisting those who need to gain access to treatment options. We provide a supportive forum to discuss and help raise awareness of mental health issues within our own communities and facilitate workshops run by professions to educate young people about mental health and well-being. Many of the people we engage with have indicated it's been the first time that they've been given a safe space dedicated to talking about their mental health. We all know that people within the African and Afro-Caribbean communities experience disadvantages in the society because of racism. And we especially know this right now because of the pandemic and what it has shown about racialized inequalities. As well as we continue engaging with the issue, and even in the lecture today, it's becoming clear that racism leads to discrimination, socio-economic realities which result in health inequalities. It is quite challenging to realize that we are more likely to experience poverty, poorer health and education outcomes, high unemployment, and because of that, we are bound to have increased contact with the criminal justice system, and of course, on top of that, face challenges accessing or receiving appropriate professional services. This is well known, and there's a lot of evidence about those outcomes and our racialized lives. We are young, yet we can see what the services hold for us. And it can sometimes feel worse after accessing the services because it doesn't feel like they understand what racism is. The hypervigilance, the stress, what you have called biological weathering, and that trying to engage with those services does not feel that safe because of the lack of knowledge. So my question for Professor Williams today is, when we have services which may well wish to help, but do not seem to understand the experiences of people who face racism and how those experiences impact on even engaging with those services if you can access them. Yet mental health services is one area which is recently shown that it's wished to seriously support this rethink. What can he suggest in order for these services to begin to reconsider how to address this?
Thank you so much for the question. I think it's a really important question. So I think there are several reactions I have to what you've said. I was involved in the first national study in the United States looking at the mental health of the Black population, and for the first time, a national sample of Blacks of Caribbean ancestry in the United States. And what we found was that the Black immigrants, first generation in the US from the Caribbean, had lower levels of mental disorder, depression and generalized anxiety disorder than the general population, than blacks in the US and then whites in the US, first generation. By the second generation, that means the children of immigrants, the parents were immigrants, but the children were born in the US. They had gotten to the norm where the rest of the US was. The third generation was the highest prevalence I have seen in any study of mental disorders, third generation Caribbean immigrants. And I still do not fully understand why we see this worsening decline from the second to the third, because the third are further removed from the migration experience. They were born in that country. Their parents were born in that country. It was their grandparents who were immigrants. But they, in our study, we found 56% of third generation Black Caribbean immigrants met criteria for one DSM-4 psychiatric disorder. It's a stunning finding. So this work, and we saw a similar pattern among Hispanics, not quite as high, but 40-something% had met criteria for disorders. So there is something about the adaptation to immigrants in this new society that seems to have some really adverse impacts on their mental health that we don't fully understand what's driving it. What I can say in general is that too often there is a stigma of mental health services from within the populations and communities themselves, and just not an openness to even acknowledging and talking to them. So one of the things that needs to happen for our youth is that they need to have adults that they can trust, that they can talk to, and adults who will affirm their challenges and their feelings, their emotional reactions to the stressors that you described that they face. But we also need to work with the system and think of what we can do in terms of working with the providers within the system so that the kind of cultural competency I described from that study in California, that they have some awareness, appreciation of what the lives of their clients are like, and a willingness and an openness to learn and understand, so they can more effectively reach them by getting on the same page with them in terms of learning from them what are the challenges they face. So I'm saying we need to think of how we support those young people on the one hand, and create particularly social ties and adults that they can trust and feel comfortable speaking to. But we also have to think of what we do within the system as well to make it more open and supportive and respectful for those young people.
Thank you, Professor Williams. A question from Caroline Lamb, please.
Yeah, thanks very much. And thanks, Professor Williams. I mean, what an amazing presentation, and enormously compelling. And I guess what struck me as I was listening to all that data you presented was that it's shocking. It's really shocking stuff, but actually it's not really surprising. And what does that tell us about how far we've managed to get in addressing some of these issues, and what a long way we've still got to go? I guess for me, and as Chief Executive of NHS Scotland, I've got a key leadership role in the NHS and social care system. But I think, as you've really accurately pinpointed, this isn't just about the health and care system, and the determinants of good or poor health outcomes start way beyond we actually get to people presenting to us. And therefore, I suppose in respect to my other role, which is as Director General of Health and Social Care within Scottish Government, what I'm really interested in is that how we join up across government, across the public sector, and fundamentally across society, how this becomes something, the game that everybody has to play, that everybody's got a responsibility here. And I'm struck too by the way in which different organisations have come together through the COVID pandemic, united in the face of a single threat, or a single vision and a single purpose. And I'd be interested in any reflections you have on how we can encourage, how we can provide the leadership to that sort of collaboration and that working across the whole of, across all those opportunity indicators that are absolutely needed to start to address some of the fundamental issues here. Thank you.
Thank you for your question. I think you've raised a really important point, and you are correct that I think we do make steps in the right direction when we have good integration of the healthcare system with the social care system, and that is one of the challenges that we face in terms of strengthening those linkages. We often have these services provided separately as distinct, but in the lives of the individuals who are facing various challenges, these are all integrated in their lives. And the more that we can create a seamless integration of linkages from the healthcare system to the social care system, the more we do that, the further along we get in solving the challenges that individuals face. And the point I would make is to do this, it takes commitment. It takes a deliberate, intentional strategy that we will, first of all, within the healthcare system, screen people about their social needs, and then make the needed referral and have a seamless transfer of patients from one service to another so that we can get at the needs. And sometimes it requires some adaptation of the ways in which the healthcare system has historically functioned, that it plays this larger role of screening for some of these social determinants and then making the needed referrals and making it easy and not making it not with too many barriers and hurdles for individuals to cross, and so they can seamlessly go from one system to get the additional help. But I would agree with you that strengthening, and there are many good examples, I think, from Europe as well as from the US, of using even laypersons from the community and community health workers and others to play that role of coming alongside the general practitioner and providing access to the additional resources that individuals face. Those are all examples of strategies that, again, is taking the context of the individual's life seriously and trying to think of them comprehensively and not just the organ system that's sick.
Thank you for that, Professor Williams. And I'm very aware of time. I wanted to, well, actually, we're going to have Pete Seaman, Associate Director of GCPH, respond in a moment, but I wonder if there just might be a chance for one more question, and I thought we should maybe give it to the youngest in the room. And Agatha, have you a second question that you would like to ask? Because I think it's something about research, which I think might be of interest for people to hear.
So my second question for Professor Williams is, in research we read or participate in, we have found that people of the African and Afro-Caribbean communities are often grouped with many minority groups, and collectively we feel overrepresented in health research. This is strangely sometimes it seems to make it difficult for us to actually understand the prevalence of common mental health disorders within our own communities, somehow more difficult to gauge. My question for Professor William is there a way for us to understand that ourselves, and for those who continue to research in this area to rethink this? It just doesn't feel right or understandable when there's a lot of research but doesn't feel helpful, or to be honest, it's just not that trustworthy.
So a really good question. It's a challenge in many places. We still have it in the United States as well. And there are two issues. One is all of these global racial categories that we use. I'll use the ones we use in the United States: black, or white, or Asian, or Hispanic. They capture enormous heterogeneity, enormous variation, and it's really collapsing. Groups may have something in common, but it really collapses multiple groups. I'll give you one concrete example for the Asian category that I showed you data for the US, and that's how the data is collected. But if you look within the Asian category, and I showed you that there are Asian category has the highest levels of median household income. Do you know there are subgroups of the Asian category? They are small, but they are immigrants from Hmong, the Laotian, and Cambodian have lower levels of income than Blacks or American Indians. But you miss that completely, and you miss that pocket of need if you just looked at the Asian data overall. And so, but I could make that point of any group, including the white population. There is variation within each group. So the ideal thing to do is to collect data that when someone says they belong to the Black group, try to understand what is their ethnic category within the Black group. And if you that systematically, one of the challenges is when the population is relatively small in a context, country, community, and so on, frequently there are too few cases in any given year to do analyses. But what we have used to good effect in the US, collect the data anyhow. And sometimes we are able to collapse the data over 3 years or 4 years, and it can tell us something about those smaller subgroups, whereas in any given year, there's insufficient data to give us any insight. So that would be the strategy I would recommend, especially when there is a population with lots of variation, but the numbers are relatively small, and so that you don't get robust data in any given year to really say anything definitively.
Thank you, Professor Williams. Thank you, Agatha, Claire, and Caroline. We are a few minutes left. Pete Seaman, I would like to ask you to
thank you, Emma, and thank you.
Response.
Thank you, Professor Williams, for your thought-provoking and challenging presentation, and the panel for the reflective place, sharing their reflections, where they've been left after the presentation. I'm going to respond not necessarily just to Professor Williams' presentation, but also in relation to thinking we've been doing in the last couple of years around this issue. We began our journey in understanding racialized inequalities in health in response to demographic projections highlighting the increasing diversity of the population. This made us aware of gaps in the understanding of racialized inequalities in Scotland. It's now accepted that COVID-19 has laid bare existing inequalities in health, and COVID-19 is a really clear demonstration how exposure to risks are socially determined. And I think one thing I went back to ahead of Professor Williams addressing us was the SOBID study, which was one of GCPH's first studies back in 2004. And I think this is an important study because we're now in a position where in public health in Scotland, poverty is understood as a risk factor for poor health on a par with some of the biological risk factors. But it must be stressed in Scotland, we do not understand to anywhere the same degree the impact that racism has on health when compared to what we know about economic impacts. Recently, the expert group on COVID-19 and ethnicity, which Emma was heavily involved in, has highlighted the shortcomings in evidence around ethnicity and health within Scotland. And it can be said that the absence of this evidence is an example of systemic biases, of choices that have been made that haven't been made. And we should highlight that it took 15 years for GCPH before we had a seminar that addressed issues of race and racialization. So there's been decisions made and not made that I think illustrate biases, implicit biases, unconscious biases around what becomes research priorities. So for me, the issue of knowledge and evidence, and it would be fantastic if Scotland was to adopt the discrimination scales and measurements of microaggressions so we could understand some of the processes which may lead to racial inequalities in health. Looking at evidence and knowledge alone will not be sufficient in isolation. To make it sufficient, we need to also think about workforce diversity. And I think the issues of knowledge and workforce diversity are inseparable. We need to open up decision-making and ensure a broader range of experiences are within the professions related to public health and public health intelligence. And at GCPH, we're hoping to facilitate a space for the development of next steps. That will include more focused events. Currently, we're thinking in terms of focused events on data, how we can address data shortages and data absences, but also to think in terms of workforce. And we've recently been joined on the GCPH team by Shruti Jain, a senior public health researcher. She's sharing her time between GCPH and Public Health Scotland. And her brief will include issues around data, continuing to ask ourselves difficult questions around how certain perspectives have been silent in the data up until this point. So Emma mentioned before an event we had 2 years ago, how racism as a fundamental determinant of health inequality. At the time when we named that event, we named it with a high degree of trepidation. We recognise that public health is a profession that's focused on equality of outcome and equality of opportunity. So to name racism as a process that can lead to inequality was very challenging for us to do towards the public health profession. So we'll be here to think also about the opportunities that an organisation like GCPH brings and how those opportunities can be opened up to those who historically have not been able to access that opportunity. So again, not just about knowledge, but also about recruitment, and also about how that recruitment and the diversity of the workforce may reflect some of the decisions made about what research we prioritise. So it's about governance as well. But it's only by making ourselves open to this process of learning and unlearning that we'll be able to show leadership in acknowledging the impact that living in a racialised society can have on health. And let's not forget, at the current time, there are still some quarters who do not acknowledge systemic racism as a problem. But this acknowledgement is required before we can proceed to understanding and acting upon its impact. And until our model of the social determinants includes understanding issues of race and racialisation, our model of social determinants will remain incomplete, and consequently, so will our policies. So we must complete this model and we must understand how racialised differences play out in Scotland, understanding the processes as well as having a better handle on the outcomes. So GCPH will be there to support through tailored events over the coming year, and we'll continue our work. But before I hand back to Emma to close, I must thank her for having the faith to work with GCPH on this over the last 2 years and helping us get to this point. Her knowledge, expertise, and unwavering challenge to us has been really, really inspirational. It was Emma who had the original idea to invite Professor Williams to address us. We didn't think that we would get him, but Emma's good at encouraging us to be brave. And it's a brave conversation that we all need to have now. So thank you.
Thank you.
Thank you for that, Pete. And it is just for me now really to close the event. Just to thank you to our panelists. Your questions, your reflections, and the work we did engaging together in the lead up to the event have been really important contributions. We all know, despite best intentions, we have had generations of reports and recommendations, often with limited accountability, that tend to document or simply restate that the problem exists. What we have had are processes which are often focused its gaze on outcomes of proving racism through documenting the inequality, proving ethnic variations in racialized inequality, but not on the assumptions, the processes, the mechanisms which create the differences across racialized ethnicities. Thank you to you as audience members, community representatives, young people, activists, third sector workers, artists, researchers, policymakers, health and social care workers, government people who all signed up to listen today. Thank you to the GCPH staff and board members who are providing this critical space in Scotland to help us think and process what we have just heard and what we know we have to do. Lastly, thank you to you, Professor David Williams. You offered help and you have already brought us together through giving us your time and your expertise. We now have an opportunity, if we choose, to build from your knowledge to create mechanisms that bring in racialised communities into decision-making fora in Scotland to bring in young people whose futures we are creating, to help critically rethink how to do this work, so we do not squander this significant, awful moment of public learning on the deep systemic nature of racism in order for us to build the anti-racist critical thinking and practice to dismantle it. Thank you.
Thank you.